don't believe in outlines. I believe a letter of recommendation should come from the heart. You should really speak on that person that you know. If it's genuine, then they shouldn't have a problem with writing a letter of recommendation. Hi guys, happy Monday. Welcome to e-Shadowing. Hope everyone's having a lovely Monday and had a great weekend. Right into it. Today's session is going to be on pediatrics. So pediatrics in the ER, of course. So we're going to talk about some things to know about handling a pediatric patient and, of course, the case study. But, of course, we're going to start off with any questions that you guys may have, typical Q&A, anything PA related, anything you even want to know about peds. Just any general questions that you have. Nothing personal, as I always say, nothing that, specific to you. If that's the case, just always send me an email or DM. So let's see. I know there are some questions. Does anyone know should I write letters of recommendation? No, I do not write letters of recommendation for doing virtual shadowing. Letters of recommendation is done when you build a rapport with someone, when someone feels comfortable enough to write you a recommendation and they know you well. So unless, I know you well, and that means that, I built a relationship with you, then I will write you a letter of recommendation. I have letters of recommendation for students on e-shadowing, but like I said, that those have been kids that have, or not kids, but students that have been following me for a while. They've emailed me. We built a rapport, as I said. They tag. It's been built to the point of like texting, communicating daily, or regularly. So yes, it's possible, but I don't write letters of recommendation for like 82 plus or 100 plus people on e-shadowing. It is a 1 hour session. You get 1 hour credit. You always receive credit for attending e-shadowing. Any questions related to e-shadowing, I don't typically answer those as well, because you can find every question, answers to all your questions on eshadowing.com. There's a frequently asked tab or area on that page. Okay, what are your favorite procedures, least favorite procedures? How would you recommend learning procedures? I honestly don't like procedures at all. If any, my favorite procedure, I used to love suturing. It just got to the point where, like the way that my hospital did it, like you would still have to see patients even if you were suturing. So I would be suturing, and then I'd have patients that were still to be seen. And if it was like a difficult suture, it was time consuming. Other patients would just be there and upset and get annoyed and whatever, and then it would delay me. And so I just grew to not really like procedures. But the ER that I worked at in New York, they actually had PA specifically for procedures or any trauma cases. Any and all traumas went to that PA. So that really helped, because we would see like other patients and we wouldn't get so backed up. So it just depends on where you work. But I'm not a big procedures person. I don't mind suturing and INDs, other procedures. I'm not sure. We don't really do much other procedures in the ER besides those. Let me see. Of course, a lot of digital blocks come with suturing. Let's see. We can do some reductions of dislocations, like typically the finger. Doctors I've always seen do larger joints. Let's see any other procedures. Other procedures such as like arterial line, central line, those are done in the ICU. Or if a patient needs a central line, the ER doctor does it in the ER. I don't do EJs and stuff. Draw blood and stuff is all fine, but like EJs, no. So yes. Do you want to stay in the ER for the time being, or do you see yourself switching in a few years? No, I just like the ER. I don't see myself doing anything besides the ER or urgent care. I'm not sure. Maybe if I was, honestly, don't know what I would be doing besides that. I think that's just what I like. What is the most common task you do during work? Most common task, probably charting. How would you, I didn't answer the last part of her question. How would you recommend learning procedures? Just repetition. Of course, I always say repetition is the best way of learning. The more you do it, the more comfortable you get with it. Our school provided suture kits, and then I also went and bought more for myself to practice. So you can just go on Amazon and there's suture kits on there, and it comes with everything, like the needle, thread, and all that. your not scalpel, the everything that you use to suture. Yeah, and you'll learn like needle sizing and all of that, and the what is it? We call it the swag for the needle, the shape of it, and yeah, you'll learn all of that in school. But as far as getting comfortable with it, the more you do it, the more comfortable you get. And you can watch, they'll teach you, you can watch videos, but buying a suture kit really, really helps. Like I said, the school provides you one, but buying one, I did it so much that like it tore, so I just went and bought my own. Questions. As a pre-PA student, would a letter of recommendation from an MD be acceptable? Yes, you can get a letter of recommendation from anyone unless they specifically say someone. I would just always recommend that you at least have one from a PA, but if you have one from an MD as well, that's perfect. What's an A line? An A line is an arterial line. So rather than going through your vein, they go through your arteries. That's usually when patients are in the ICU and they monitoring their arterial blood gases. How has it been in a situation in which you disagree with an MD and need to yield given our hierarchy, even though you believe you're right? Yeah, I've been in that situation before. I just called the medical director. I called the medical director. It depends on the personality of your medical director, if they're helpful, if they're a good leader. The medical director I work with, he was amazing, like one of the best bosses I've ever had in my entire life. He was just superb. This was the one in New York. He was like amazing. And like there was a situation with a doctor, and I just, kind of went back and forth with the doctor a little bit. And then, I was just like, I'm just not going to do this. I'm not going to argue with you. I'm going to just call up, the medical director. The medical director is the head of the ER. As far as the medical side, not nursing. So MDs and PAs. So I just called him up and said what I had to say, and he was very nice about it. And he told me, don't do anything I'm not comfortable doing, and to just let the doctor take care of it. And that's exactly what I did. I'm not going to go into details about it, of course, because it's personal. But what about the ER makes you love it? I just love the excitement and seeing a bunch of different things and learning. And I'm a natural adrenaline junkie. So I'm not going to say there's always excitement. There's not. And I also love just seeing patients go from like sick to slightly better, or like the improvement and throughout the course in the ER. And then finding out the case, as I always say, it's like a puzzle. Bring a puzzle together. You find out this, find out that, or playing, what is it? What's that guy? Clue? Not Clue. Inspector Gadget? No, I don't know. Just solving a problem. Sorry, guys. But yes, I love just the whole problem solving aspect of it, and seeing the labs come back. Like I said, seeing the progression of the patient, figuring out things as the lab comes back, because it's not always textbook. So something may be crazy, and I have to sit there and think about, okay, what could be causing this? I love the whole, critical thinking. Yeah, so that's what I love about the ER. I don't think you do that with others. I think other fields, you see a lot of the same things like every day. Not that you'll always see a lot of the same things, but you get used to I wouldn't say bored, but I don't know. I guess you get comfortable, but I like in the ER that you don't, like that you're always hit with something weird and crazy, or typically are. Like there's always at least one crazy thing in the shift. I kid you not, especially depending on where you work. Like if you work in the inner city area, just prepare for some excitement, okay? The ER, if you looking for a rush in your job, a rush as in like fun, then an inner city ER is it. Are you still in the ER in New York? No, I'm not in New York. Are there things that you're going to look for in your next locum tenens position? Yes, so I'm not in New York anymore. I may do locums again. I actually want to do locums again, but I may not do it until like December, or winter fallish, because that's when like it gets more needed, because it's that time of the year, especially in certain areas with like cold and flu season and snowbirds. So I may do it then. What I really want in a locums is them to provide housing. That's so important. The last one did not, but they compensated in the pay. But housing is so, so, so important, because I just had to go from Airbnb to Airbnb, had issues with Airbnbs, had to stay at hotels, and then I had to, check out my Airbnb at a certain time, and then I had to go find a hotel. Like, it just takes the relief off of that if they can provide housing. Most of them do, but like I said, this one was like a COVID one, so they just like kind of tell you what they can and cannot do. or what they're willing to do. But yeah, you shouldn't have a problem with housing. So make sure that they cover your housing and transportation. They'll either provide you a vehicle or you'll have to rent one, and they'll cover the miles. And they'll pay, of course, for the rental. And then, of course, pay. They typically pay more. I'm not even going to discuss pay. What outline should you give a PA to follow for a well-written letter of recommendation? I don't believe in outlines. I believe a letter of recommendation should come from the heart. You should really speak on that person that you know. If it's genuine, then they shouldn't have a problem with writing a letter of recommendation. So that's what I always do. If I don't feel comfortable, if I don't feel like I know you well enough, or feel like I can attest to you, then I won't. But so I need to know enough good things to say about you, so I can have a strong letter of recommendation. And yes, people I have written letters of recommendation for have got accepted into PA school. I don't think a letter of recommendation is going to be the end all be all. I don't think my letter of recommendation got that person into PA school. I mean, it could have helped, but of course, ultimately, it's up to you. But yeah, I don't believe in writing one out and then the person reads it and whatever, or following an outline. Just speak from the heart. I'm all about that. As far as anything, just speak from the heart. Tell the truth about that person. I mean, but if you wanted that, there's a bunch of stuff on Google. Okay, let's see. Oh yeah, somebody asked me about what I would do if I wasn't doing that. And then I just read something about, oh, have you done cosmetic procedures like Botox and fillers? I would probably do that if I didn't do the ER, only because like I don't know, like I would just it's a relatively fun and less stressful environment. So if I was looking for a more relaxed, high paying job or specialty, I would do that. I would go into cosmetics. So Botox fillers. I have a friend that's actually just started doing that. What made you choose PA rather than NP? Because it was a more doable route for me. Because I already had my degree. I didn't want to go back and get a nursing degree, then work, then go for an NP degree. So, was adapting your bedside manner to work with kids difficult, or did your pediatric clinical rotation PA school help with this? I mean, if you look at me, I'm like a kid too. Like kids think that I'm their age. I mean, I'm 5 feet tall. I mean, other than my haircut, that kind of lets you know that I'm an adult. Like, I'm just a goofball. So it didn't take much to adapt to kids. I just laugh and tell a joke and, put on a Coco Melon or something on my phone. Especially when I'm doing sutures. Like, when I'm doing sutures, I hand them my phone, let them watch whatever they want on YouTube. And the parents love that. They don't have to use their own phones. But yeah, I just give them my phone and let them do whatever. I mean, I don't have to, but I just do that. I naturally love kids. So if you don't like kids, then yeah, it may take some adapting and you'll learn that in your pediatric rotations. But if you have a natural affinity for kids, then yeah, it's going to be easy. But that does not mean that I like pediatrics as far as the field. I love kids, but I do not like pediatrics. I mean, I'm not fond of pediatrics. And I'll tell y'all later why. Are you able to follow what happens to your patients after you see them? If they're admitted, yes. If they're admitted, then you can, follow, see the chart, see the hospital list report, any other specialists that they saw while in the hospital. If they leave, unless they're under that hospital system, typically no. If you want to know about like how they're doing, you just call them up. You can call them up and follow up with them. So typically, I mean, like I said, it depends if they're admitted or not. I don't work in New York anymore. When I did, I worked in Brooklyn. Where did you go to PA school? I went to Nova Southeastern University in Florida. Southwest Florida. Do you have to screen and triage patients? I do not triage patients. I do screen patients. Yes. Well, screening, yeah. PA screen patients. It's not all that you do. So they'll break up like your assignment and which part of the ER you work that day. I work night shift, because I work night shift, typically screening ends because it's not as busy, and they do only screen when it gets really, really busy. And more busier times of the day, as I said. So, and screening is just a way to kind of get things started. They see a provider. You don't do a full assessment. You just kind of ask, oh, why are you here? Blah, blah, blah. And then they put in some basic labs, and kind of sometimes they don't even have to do a physical, just to make sure the patient is stable and okay to continue the workup in the ER. That's basically what you document. And that you start some things if need be, you can give them a little bit of medications, typically just Tylenol or Motrin, something safe if need be. And yeah, and then that they basically wait to actually be seen by a provider and have the full workup. So that's what screening is. All the hospitals I've worked at do it. I think all hospitals do it. I used to work day shift. So when I was working day shift, yeah, they screen patients. Small hospitals, I'm sure, don't do it because they don't need to. I didn't do it when I worked at my 9-bed ER. So, like I said, if they do need it, they don't. They need it, they do. They don't, they don't. So when I screened patients, that was it. But when I did night shift, I didn't have to screen patients because night shift's not as busy. What is the biggest difference between NP and PA? Really, the way they get taught, their education. Anything up to that is, once you start working, really, we work together. We do the same thing and see the same type of patients. And then it also depends, actually, it depends on where you work and the culture of that area. Some places are more receptive to NPs versus PAs. Some places don't allow NPs to do this versus that, or this for that. Like PAs are probably like up north, NPs kind of rule the whole OBGYN or midwife thing versus PAs. I don't know. But it really depends on the area and their education, how they're taught. It's like nursing model versus medical model. And yeah, the area. Some places, like I said, are more receptive to PAs than NPs. Would it be worth it to shadow an NP? No, do not shadow an NP. Not because that they don't know, but because it's not gonna really benefit you. Because we do a lot of the same things, but if you're looking to shadow an NP for shadow hours, it's not going to count. You want to shadow a PA or an MD. Is there a specialty besides anesthesia that PAs cannot do? Yeah, I don't think so. And the only reason PAs don't do anesthesia, I believe, is because there's anesthesiology assistants, and then there's also CRNAs. So that field is already, or specialty is already is Howard an accredited program? Last I knew, Howard was under probation, right? Yeah, I think Howard was under probation. I'm not sure their status now. So I would check the RPA website. Do you have a state-specific license for each state that you practice in? Yes. So that's another thing with locums or if you want to just move, you need to get a state license for every single state that you practice in. They have different rules. They have different, governing bodies. So you want to make sure that you are licensed to practice in that state. Your certification basically says that you're certified to work as a PA, but the license is different. You want to make sure that you have a license to practice in that specific state. So I have a New York, Florida, and Georgia license. And you have to pay every 2 years to renew your license. You don't take a test, or not generally. Some states require you to take like some stupid tests, like Texas, to get a license. But because I wanted to practice in Texas, but there was that test. I wasn't going to do that. Hopefully they don't need that test. I'm glad that. Any advice on how to find a PA to shadow? Okay, so PA to shadow. So I know it's hard. Right now, I do have a surprise for you guys, but I can't. But PA to shadow. I've been saying to go on LinkedIn, to create a LinkedIn profile, make sure, it's very professional, have a bio, tell a great bio about yourself, upload your resume, highlight yourself, and, make sure it's a professional photo, and then look up PAs and MDs in your area, befriend them. Don't just message them, oh, I'm looking for a PA to shadow. No, you first befriend them, just say, I'm, blah, 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 my name's blah, blah, I'm a aspiring PA, and I would love to follow you just, to learn more about your work. Boom, you send that message, and then you kind of like their stuff, make them, kind of notice you a little bit, and then like a few days later, message them then, asking if you can, or if they have any shadowing opportunities or know anyone that wants to shadow. So I just recommend you just go on a follow spree. Just follow. You got to get in where you fit in. So if that's what you got to do, that's what you got to do. So, and then also join Facebook groups, join any and all PA Facebook groups that you know of, post to those Facebook groups saying that you're looking for a PA to shadow. If you're part of a PA club at your school, do that also, network. Also, you can post on, if you befriend PAs, if you guys are in any PA groups, like I know you guys created group meetings and stuff, and find PAs in your area or pre-PAs or PACs, PASs in your area. Reach out to them. Network. How did you track your shadowing hours? I just wrote them down. I wrote them down on paper, and I think I created like little Microsoft Word table, and yeah. I have tried calling medical offices. Yeah, so I didn't say that yet because I didn't think people did that anymore. So, 'cause that's what I did. I basically went through the whole white and yellow pages and called and offices, and you can do that too. But I do have something exciting to help alleviate this. Do you have any insight into what it's like working in a rural area? I actually did work in a rural area. Like I said, it was a 9-bed ER. It was in like the middle of nowhere in Georgia, like super country. It was very new to me because even though I'm like a suburban girl, I've always lived near the city. I like the suburbs. I like peace and quiet, but I like being able to go to the city. I don't like country. Okay, so I'm just right there, and I don't like too city. So that's why I don't like. I didn't really wasn't too fond of New York. I don't like too many people. I just like just a good amount. But yeah, it was very different. A lot of them, as I said, I don't know if I've ever actually said this, but a lot of patient teaching. A lot of them were actually really sick because they are not that, I'm not gonna say not educated, but they don't have access to medical care. So what you read about is really it. Like they really do need providers in those areas. So that's why there's scholarships for working in a rural area. Let me tell y'all. So I worked there for a year. I could have stayed for 2 years, but by the time I started working there, I was like, oh my gosh, I should have applied for that scholarship to get my loans reimbursed, but I forgot. But yes, if you work in a rural area and it's like accepted by the website, I forgot the name of the website. I can look it up for you if you guys are interested in it. But you have to apply, I think, either before or when you start working there, and it has to be one of their programs, or you can apply for where you work to be on their list. But it has to be when you start. So if you guys are interested in that, I'll either post a link. I can't find the link right now. I don't want to stop and look for the link, but just email me and I'll find it for y'all. So yeah, it's very different working in a rural area. It takes a lot of getting used to, a lot of education, a lot of learning, just respecting their cultures, what they think is such and such, their diets, educating them, but at the same time, not judging them and respecting them. All right, so it's almost 7:30. I'm going to start the case study. Okay. Any other questions? Maybe answered next week or email me. I'm just uploading the case study, guys. Just don't want to. Okay, here we go. All right, maybe I'll answer one more question. Most doctors' offices are not allowing shouting. What are some opportunities I can do to set my foot in the field? Other than work right now, and because COVID, is kind of picking back up and things are crazy, they're probably going to go back to that again as far as restricting students. I'm sorry for that, but the only thing is to just work, get certified, and work besides shadowing. I mean, of course, there's e-shadowing, but the only thing is just to work, to get your foot in the door. Okay, here we go, guys. All right, I know my normal flow, what I typically do. So today is Pediatrics Day. So, of course, you all should know this by now that in the ER, you want to think about the worst first. You want to think about what can kill your patient when you see the patient. This is all discussing your differential diagnosis. Differential diagnosis is just what you think could be going on with the patient in terms of, their diagnosis could be. And you're going to structure your treatment plan, structure everything you do based on that. So always be thinking about what could be going on. All right, for pediatrics is different from adults, similar but different because you have little kids involved. And when you're dealing with kids, know that you are dealing with their parents, okay? So that's what's different from adults, okay? And people do not play about their kids, okay? So that's why the first point is that parents are always right. Are they technically always right? No. We may know, may say, oh, this patient is diagnosed with this, he needs this. But if the parent says, no, I want my kid to have that, boom, that's it. You explain to them risk, benefits, what can happen if they don't get it, everything. You explain it to them, everything, do your job, and then boom. If a parent complains, just always be respectful. Always know that what they're doing is because, or the reason that they do this is because they love their kids. They love their kids. They're worried. It's another human being you got to worry about, and they're worrying about. So it's a very touchy and sensitive area. That's how I feel like about peds. That's why I don't really like peds. I don't like dealing with their parents. Because it's like, you got to think about how it is as a parent when you have a sick kid. You know, you're already stressed. You're already really worried. You're not sure what's going on with your kid. If you don't know medicine, you don't know medicine, but then to have, you don't know medicine, then your kid is sick and you're like, you don't know what to do. But then you feel like you know your kid and you know that something's not right with your kid. So you have to tell the doctor, okay, I know something's not right with the kid. The provider has to figure it out. So parents are always right. Just be respectful and listen to what they have to say. Okay. You know, when they say customers are always right, even though they're not, just think of it that way. So it's just different from dealing with like a regular adult patient, dealing with a parent. And sometimes they don't even let the kids speak, even though when the kids are able to speak, they, have enough knowledge and age to speak, but they don't. They kind of just, want to take control and be controlling. That's fine too. Just document, everything and that you did your job, but know that you're dealing with two people. You're not dealing with just one patient. You're dealing with the parent too. Okay. And then of course, it's mg per kg dosing, which is weight-based. It's always weight-based dosing. I think once they hit like age 16, of course, 18, you don't have to really worry about that. We'll always remember mg per kg. Okay, I mean, the way EMRs are now, it's going to automatically show you that when you order the medication, it's going to show it in mg per kg so you know what to do. And then a lot of times, it'll calculate it for you too, so that's less room for error. But you have to remember to get the weight, the up-to-date weight. Some people forget that, if a kid was seen 6 months ago, they're not going to weigh the same, especially if they're a teenager growing. So make sure that there's an up-to-date weight. As long as you put that weight in, or the nurse puts it in, or you make sure that weight is up to date, and you'll see that like the last time they had their weight checked. So as long as that's up to date, your EMR system should be able to do everything else. So whatever it say they need to be on calf legs, you put it'll show you the weight for the calf leg, the weight-based dosing for the calf legs. It'll have like the weight-based dosings available. Say like if it's 5 mg per kg or 7 mg per kg, the strength, and you can go on Hippocrates and see what you want to give, whether you want to give 5 mg per kg or 10 mg per kg, and it'll tell you what they recommend based on that patient's age on Hippocrates. So once you select that, it'll already calculate it for you, okay? But still make sure you know your calculations, because if something don't look right on the computer, you can just double check on your phone. So know how to do mg per kg calculations too. So that's another important thing with pediatrics. Also, just double check every medication that you're going to give the patient. Pediatrics can't have certain medications like Bactrim, like at a certain age they can't have it, like Motrin. I should have had that been a question for you guys. So like Bactrim, ibuprofen, ibuprofen, babies can't have it if they're less than 6 months old. Let me see. Just always check if you're thinking about giving a child a medication. Just like the pregnant patients, I just always double check on Hippocrates to make sure that, the patient can get this medication and that they're at that age that they're able to get it as well. So double check all your meds, double check to make sure that they're getting the appropriate weight-based dosing, that they're not getting too much or too little. And also just document. Okay, document. Make sure you document. If there's ever a time to have proper documentation, it's when you're dealing with the child. Okay, things will come back to haunt you, especially with peds. You never want to be a reason to harm a kid. Okay, so document. If an issue arises with a parent, document every single thing. Listen, my documentation may be a paragraph long. If something happens with a parent, I'm writing every detail. I don't care. Okay, so document. Somebody had a good question. If the parents always right there is a minor, emancipated, married, pregnant. Okay, for pregnant, if they're pregnant, no. If it's an emancipated minor, no. There's situations where, no. I don't think you can be married. What age is it to be married? I mean, that all varies with where you live, actually. I don't know about being married. I mean, because can you get married at, like, what age can you get married in the United States? I don't know. But you'll find all that out. You'll find all that out. As far as marriage, I don't know. But pregnant, no. Pregnant, if they're like a minor, pregnant, you can do a pregnancy test if they're like 16. But like I heard about a 12-year-old coming into the ER pregnant, or coming into the hospital pregnant. This has nothing to do with me. It's never happened to me, but I just read it online. So you have to call the police if they're like a minor and they're like, and you think that whatever, like rape or whatever could be going on, it's illegal activities, call the police. But all of those are kind of sticky areas. So I would either get social services involved or just confirm it with social services. Ask the nurse too. But yeah, those are little tricky areas. Thankfully, I've never really had to deal with them because pregnant patients, even though they can kind of consent for themselves, they've always kind of shown up with their parents too. Oh, I actually did have a pregnant patient, and what did she come in with? I forgot what she came in with. I think it was like abdominal pain or something. And she was found to be pregnant. I think she was 16. I couldn't tell her parents. I told her, I can't tell your parents. Her parents were with her because she had abdominal pain. I was like, what do you want me to tell your parents? And, she told me, what she wanted me to tell her parents, but I could not tell her parents that she was pregnant. That's for her to share that information. So yes. Ooh, no, I did not mean to put chest pains. How? No, yeah, this is from another slide, but just read the chief complaint. All right. I have a 12-year-old patient that presents to the ER with his mom with complaint of redness and swelling of his left arm times 5 days. So this is a 12-year-old patient that's just waiting in the lobby, okay? The ER waiting area. He has a sweater on, so you can't really see his arm. All right, let's just say that. His vitals look fine. Does anything stand out to anyone? All right, nothing stands out to me. I mean, his temperature, he doesn't really have a temp. The temperature is like 101.3 or 101.1. Anything above really 100. I mean, I raise my eyebrow anything above 100. 99 is okay to me. Maybe super low grade. 99 is actually still normal. If it's like 99.9, it's like more low grade. But yes, his vitals look fine. But what should you be thinking about this patient? What would you ask this patient? So this is a 12-year-old, so that they're preteen, they're able to talk, able to provide a history, unless they have a past medical history where they're not able to provide a history, they're mute, whatever it is. But other than that, you can ask both the parent and the mom questions, okay? All right, so what are some important questions you'd want to know if the patient has redness and swelling of the arm? Any allergies? Okay, you'd want to know if maybe it's a possible allergic reaction. Did you fall? Any trauma? Any injuries? Right. The first thing I would want to know if he had any injuries, like how did this happen? I mean, he's a preteen boy. Could have been related to sports. Could have been like outside playing. He tripped. He fell. Anything. You just never know with kids. So ask about any trauma. Let's say he had no trauma. Let's say he had maybe it's a splinter trauma. Maybe he had a splinter or something and pulled it out. Okay, he didn't really have trauma. He had a splinter and then pulled it out and then bam. This was a real patient. I just don't remember everything because this happened like 2 years ago. So I'm going to make some stuff up. Activities around that date, that sounds great. Burn, sports, bug bite, yes, awesome. So these are all questions that you want to know. It's not really painful. It's a little tender to touch, so you don't really have to do OPP, QRSTA. You can ask, of course, you're going to want to know about the onset. You can ask if it's very painful, so you'll document that. You can ask if anything seems to make it better, if the mom has done anything to help with the swelling and redness. Say she's been giving him Motrin, but it hasn't been helping. You can ask that. Important questions to know, of course, is the major thing is trauma. Ask if he's had any injuries. Ask if this has ever happened before. Let's see. Oh, this is actually physical. We'll talk about that later. But ask any allergies, any new medications, you want to rule out all the allergic reaction type questions, any new meds, any allergies. Have you traveled around recently? Anyone else at home could have the same thing to make sure it's not like scabies or something. I don't know. But you want to rule all that out. Let's see. We said, has this ever happened before? Painful. It's not really painful, only when you touch it. Or maybe it is painful a little bit more than when you touch it. Who knows? I don't remember what the patient said. No, chief complaint was not both chest pain and redness. I just forgot to change the title. This has nothing to do with chest pain. I'm so sorry. I try to make sure I change it. I do these a little earlier, but I got home late today. I literally came from my flight to home. So I had to put this together. I've had a busy weekend. But yeah, it's not chest pain. Nothing has to do with chest. This is about arm pain or swelling or the diagnosis that we're going to talk about. All right. So we're asking these questions. So the most important thing you want to know is about trauma, any injuries. Then you want to go to your past medical history. So what important past medical history do you want to know for patients that present like this? Not just pediatric patients, but patients that present like this. Why do you want to know this? is. What important past medical history? Anyone know? Any surgeries? No. Allergies? No. We already talked about allergies. No. We already talked about allergies. Cloggers? No. We already asked if it's happened in the past. No. Past medical history? No, not past surgical history. Chronic conditions? You're in that ballpark. You're in that area. Up to date on vaccines? Okay, yes. Somebody said that, but that's not it. But you do want to know about vaccination status for all pediatric patients. But that's not what I'm talking about. No, what they're allergic to. No, we already talked about allergies. So what you want to know, somebody said chronic conditions, which is yes, you want to know chronic conditions, but specifically you want to know, make sure that they're not immunocompromised, because that changes the course of things. If this patient has an infection, if your immune system is not good, then that can make the infection worse, or it can make you not be able to have a hard time, cause more complications with this infection, right? So you want to make sure that they're not immunocompromised. You ask them their medical history, but you ask them specifically if they have certain conditions that cause you to be immunocompromised. And you just kind of say, especially, sticky, sensitive subjects like HIV or cancer or whatever, you just say, no history of this, no history of that. Just want to make sure, because you have an infection, it can complicate infections. Boom. And then another specific condition that can complicate infections is diabetes. Okay, you want to make sure that the patient is not a diabetic. Typically, diabetics have to be on 2 antibiotics if they have infections, and then it's harder, especially if they're lower extremity infections like in the foot. If they have neuropathy, they're not going to feel it. They'll come in with a toe wound or something like that, and they'll have it for say 2 days, and it's crazy. It's crazy how diabetic infections progress. It'll go from a small cellulitis to osteomyelitis. And osteomyelitis is when the infection spreads to the bone, that stuff. So yes, you want to know specifically patients with infections or suspected infections. You want to know if they have any medical history that causes them to be immunocompromised. If it's a cancer patient, you're dealing with a whole different ballpark, okay? Versus a patient that's perfectly healthy. They may need, like I said, 2 antibiotics. It may get more complicated. You want to, if they're, have immunocompromising conditions, and you want to make sure that sepsis is not on top of that is not causing a bacteremia, all that good stuff. Yes, somebody said a patient had a spider bite that led to amputation due to diabetes. Yeah, I'm telling you, diabetes, you don't want to play with it. Bacteria loves sugar, so when they get in contact with that sugar, if you have a lot of sugar, it's just gonna run rampant, whatever that word is. Okay, so yes, past medical history, past surgical history. Yeah, that's fine to ask. Family history, that's fine to ask. Social history, of course, tobacco users. If you smoke tobacco, delayed wound healing, but it's not as crazy as you want to ask about immunocompromise. All right, so what systems do you want to assess? Usually I'll have this here, but I want you guys to start answering these specifically because it's focused, right? So what do you want to specifically look at? Focused history with redness and swelling of the arm. What do you want to specifically look at? Endocrine? No. And you don't really do a physical for endocrine system. I don't know what you would look at. I mean, if they're diabetic, sure. I mean, if it's palpable goiter, but that's hypothyroidism, but no. Musculoskeletal. Yes. Integumentary. Perfect. Yes. So, yes. Okay. Heart, lungs, and okay. Perfect, guys. So, you want to do a skin assessment, of course. Check the skin, redness, swelling. If there's any drainage anywhere, if there's any open wounds, if you see any redness or swelling anywhere else besides the arm, if you see any rashes, any lesions, anything, any vesicular lesions, redness, so do a proper skin assessment. With the skin, it's great to look everywhere. Okay, you can have the patient change into a robe and just kind of fully look at their entire skin and make sure there's nothing else going on. Sometimes if the patient doesn't want to, you just ask them, okay, do you have any redness, swelling anywhere else? Can I take a look anywhere else? Sometimes they'll say no, it's just the arm. You just document that. But you want to also do, depending on where it is in the skin, you want to do a musculoskeletal. So this is his arm. Even though he says he has no injuries, skin infections can cause you to be unable to move your arm. And if it gets to that point, then it's bad. If you're not able to do range of motion, then that's not a good thing. So you want to check musculoskeletal as well. And you want to make sure that there's no joints involvement, or if there is joint involvement, you want to document all of that. There's a bad skin infection that is called flexor tenosynovitis. Bad. It's like you'll learn about it, but it's basically like in your hand. It causes like digit swelling and there's all these signs for it, but it's a bad infection. But you'll do like certain things, range of motion tests for that too. But you just want to do range of motion tests for any skin infection, really. Any cellulitis. Make sure that they can move their arms or legs. Nothing else musculoskeletal is affected. Heart, lungs, yes. Always listen to heart and lungs. And then another thing, because of this diagnosis, okay, well, with infections just in general, you can like palpate their lymph nodes, okay, make sure that there's no lymph involvement. With infections, you can have lymph involvement, just your immune system reacting to it. But this specifically, you want to check their lymph nodes, okay? All right, so on physical exam, you see this. Okay, the kid, I honestly don't remember if it was his arm or his legs. I think it was his arm, but his hand was more red than this, and it was slightly more swollen, but the streaking was not as bad, but he did have some streaking, okay? So on exam, you see this, okay? Do you guys know what the diagnosis yet? No, I don't expect you to know. I'm just gonna, let me not play with y'all. Okay, so on exam, you remember what you see on exam and know to document. So you can just document as red streak. I don't know any other way to say it. Okay, somebody said it, but y'all are too smart for me. So you want to order some labs, right? So next you want to order CBC, CMP, like I told you guys, CBC will check the white count, check your neutrophils, make sure that if it's, of course he has an infection, but it'll also tell you, if it could be a bad infection. If it's a really, really high white count, then you want to make sure the patient's not septic. This patient wasn't really, it wasn't screening sepsis, or I wasn't like too crazy about sepsis because his vitals weren't crazy. Remember, sepsis, you want to look at their vitals. It's along with their presentation, how they look, but really vitals are going to tell you it's the abnormal vitals basically on top of an infection. And then their lactic acid will be elevated. So this person was not like screaming sepsis to me. He wasn't screaming sepsis, nor was he screening sepsis. I'm sorry, I laugh at my own jokes. Okay, so, but being that he still has an infection, being that you see the red streaks, I would still order these specific tests. So you see CRP and ESR are inflammatory markers. And then that just tells you that, there's some type of inflammation going on. Clearly you see he has inflammation of his arm, so those may be elevated. But what specifically would you want to order for this patient? I already kind of gave the answer out. Like I already told y'all what I would order specifically for this patient. So what would you order? Somebody said you would do a neurological. That's really good. That's a good point. No, you don't necessarily have to for this patient. If they came in confused, really confused, and vitals are abnormal, then you could be thinking about like meningitis or encephalitis or something crazy. But I didn't do a neural exam, and I wasn't thinking about that with this patient. Yes, Carissa, so smart. Blood cultures. Yes, so you want to do blood cultures on this kid. Along with lactic acid, because even though he's not screaming sepsis, you just want to make sure, but blood cultures, you want to make sure that it's not, the bacteria has not progressed to the bloodstream and causing a bacteremia, because then of course that's bad stuff. So blood cultures, and blood cultures don't come back right away. It's like do like 1 day, no growth, 2 day, no growth. They'll do it like up to 5 days to see if any bacteria grows. So it'll start coming back like the next day or so. Yes, so blood cultures are very important. You don't do blood cultures on all patients that have skin infections, of course. I said that this patient, when you see this, you want to make sure that you do. But not all skin infections get like a full workup. Some of them, like a simple little cellulitis, you can just go home with antibiotics. But like I said, it all depends on the presentation, the labs, the physical. So yes, everything's not textbook. Everything's not, straight in a dotted line. Okay. Okay. So with this patient, would you do any imaging? Any imaging on this patient? What do you do when you're waiting for the cultures? Perfect question. So while you're waiting on cultures, you just start them on antibiotics. So they want you to do blood cultures before starting on antibiotics so you get an accurate result. Sometimes that's not always the case. But while you're waiting on blood cultures to come back, you start them on what's called empiric antibiotics, which is basically antibiotics like broad spectrum, which is able to target like many different bacteria until you get a specific report on what kind of bacteria it is and what antibiotic will target that bacteria. But you just start them on empiric antibiotics. I'll go over that. I actually should have written that down, but I'll go over that and tell you what I would start this patient on in a few. All right, so would you do any imaging? I did not do any imaging on this patient. If the patient said that they did have trauma, if I noticed like anything like abnormal, if I thought could be like, if it was a diabetic, yes. If the patient's a diabetic and like they had an open wound, an ulcer or whatever, yes, you do. And that's because you want to make sure there's no osteomyelitis going on. But it's a kid, no medical history, no trauma, able to move fine. I don't think that anything bony related is going on. I don't think the kid needed any imaging. Maybe eventually down the line, maybe if the hospitalist wants to, but it's not something urgent. It's not going to really help with the diagnosis. So I did not do imaging on this patient. If there was trauma, of course. If you thought osteomyelitis, of course. Do you know why there are some that order blood cultures every day when the results didn't come in yet? I don't know. Is that a hospitalist? Because we don't order cultures, but unless something's changed. I've never seen anyone order blood cultures every day. Maybe you're looking at the results coming back in, because it'll show you the results each day in case that there is growth one day or there's a growth in a specific tube. I haven't seen them order. Maybe they'll order it like, if the patient's hospitalized for 5 days, they'll order it one day and they'll order it like day 3 to make sure that nothing's changed. All right, let's look at their labs. His labs. All right, so white count, we're just going to look at abnormals. So hemoglobin's the what is it? 10.7, 107, whatever. Oh, that's fine. Not too high. Okay, well, just look at the white blood cells. White blood cells is 12.3. High. Hematocrit, it's low because the hemoglobin is low. Red blood cells fine. All those not unremarkable. And then neutrophils. So neutrophils are like a type of white blood cell, right? So they tell you they'll be high when there's immature white blood cells, and that's because there's an infection going on in the your bone marrow is producing more at a rapid rate to help fight that infection. So sometimes I'm not saying that it's always going to be high, but you'll find it high with the white blood cells. And if there's like the percentage is high, you'll be like, oh, there's band neutrophils. Bands are like the immature white blood cells. So these are all just part of your immune system, helping to fight infection. So when would the white blood cell be, when would the white blood cell be low? When, like, abnormally low, like super duper low. When would that be low? And you have to be careful because of that, because it does not mean that there's no infection going on. So when would it be low? Anybody know when it would be low? Yes, immunocompromised. Okay, yes. So if somebody has HIV, then they're white. They have no immune system, right? They have no way to fight infection, so it would be low, and that's normal for them. That doesn't indicate that there's no infection going on. It's just that's what's going on. Steroids would actually make you have a high white count. Good job, guys. All right, CMP is perfect. Okay, so with the CMP, just a little quizzing you guys. This has nothing to do with this. So what would be a regular high, a normal variant for children? What CMP results would be a normal variant for children, especially, kind of elementary, middle school age children? Sometimes babies too. Babies can have a high amount. Just kids in general will have it. This will be high, but it's nothing like don't go crazy. Because when I first saw it, I was like, oh my gosh. But the doctor explained to me that, that's like why it is. Okay, so that's one thing that you'll learn. Unless you learn it in PA school, I didn't. Okay, so what would be high on the CMP in a child that if you see it, it's not like crazy, like it doesn't mean that the kid is dying? Sugar levels, no. Calcium, no. So calcium may go with this, but the alk-phos, so alkaline phosphatase would be high, if there's liver stuff going on, but specifically in kids, if there's bone, remember, if you're a kid, your bone's constantly breaking up and building, there's high osteoblast activity, especially if they're going through a growth spurt. So, kids are just rapidly growing. So those will naturally be high in kids, and then they'll normalize as you become an adult. Just a little. So when you see it on rotations and they be like, oh my gosh, how did you know that? They'll be like, you're so smart. I've never had students catch that. You'll be like, dang, I've been knew this even before I was a PA because of Rodeline. Okay. Okay. So, all right. So CRP and ESR, as I said, are inflammatory markers. Let's just say that they're elevated. Lactic acid is 1.5, which is normal. And then blood cultures are pending, okay? The good thing is lactic acid wasn't high. All right. So see, I mean, like I said, these two are going to be elevated. There's an infection going on. All right. So dang it, I didn't take out chest pain again. I didn't mean chest pain. Bands are immature neutrophils. It's infection. It's a sign of an infection. Somebody said, what does it mean for someone to have bands? It's like the percentage of immature white blood cells. So you'll look at the neutrophils. There's like absolute neutrophils and blood, like a percentage. So if that percentage is high, that means there's a lot of immature white blood cells. So that means that your bone marrow is making like these rapid. Think of it as when a patient with sickle cell has high retic count. Retic count are the immature red blood cells. So if your immune system needs to fight something really quick, or your bone marrow, your body just in general, they're gonna make it fast, right? So they're not making it as they should. So they're immature. They're coming out. So that's what's gonna show, is because it's an infection. Somebody said you rock as an instructor. Thank you. I try to be funny so you guys can also remember some stuff. I mean, I also try to be funny just because that's how I am. All right. So the diagnosis, who said lymphangitis? Was it Carissa? Somebody said lymphangitis. If you said that, you're correct. Ding, ding, ding. Perfecto. So this patient has a cellulitis, and then the red streaks tells you that there's something going on that is likely spread to the lymphatic system, which is not good because the lymphatic system is all over your body. So you want to prevent it attacking your blood cells, right? Your blood, and causing a bacteremia. So if it was just a cellulitis, depending on the type of cellulitis, the patient can go home, depending on how bad it was. With cellulitis, if a patient comes in when I think that they have a cellulitis, sometimes I don't even do blood work, depending on how bad. If they do need blood work, I'll just do like either a CBC or maybe CBC with a CMP if I want to make sure that their kidneys are okay, if I want to give a specific antibiotic. And if they look fine, I think that they'll be fine with outpatient antibiotics. Like I said, then they'll go home. Or if I think that they're reliable enough too as well, they'll go home. But if it's like both extremities, if it's really bad, then I'll try to work to get them admitted. Sometimes the hospitals will be like, oh, they don't need to get admitted. And then okay, you just document that. But if it's a really, really bad cellulitis, they get admitted. And if it's lymphangitis, I always admit any lymphangitis because, like I said, it can spread rapidly. You're talking about your lymphatic system. So it's all over your body, the lymph drainage system. So you want to make sure that they're on IV antibiotics, not just oral. And the hallmark for that is the red streak. That's how I figured it was lymphangitis on this kid. He really did have it. I don't remember which arm, if it was an arm, if it was a leg. I don't remember what happened, but I just know that I had a kid with lymphangitis. So with infections, okay, so you guys know that staph and strep are a very common bacteria. Staph lives on your skin, and bacteria lives everywhere in your body, but when it's where it's not supposed to be, things go crazy. Like UTIs are due to E. coli going from your gut to your urinary system and causing the UTI. So staph is on your skin, but when there's a way for it to break in and go inside your body, then that's when it causes havoc because it's not where it's supposed to be. So staph and strep are common bacteria. It's great because there's a lot of great antibiotics that treat them. But if you're thinking about MRSA, which is the more complicated bacteria that'll need specific antibiotics, then you're in a different ballpark. And with patients with lymphangitis or just complicated infections or compromised immune system or diabetics, I always try to also treat for MRSA. So like I said, I'll give 2 antibiotics. I'll do something that broad spectrum that covers MRSA, and then I'll do something like Rocephin. Well, Rocephin is actually a really good broad spectrum. So I'll do something like maybe Rocephin and Bactrim, or Keflex and Bactrim if they go home. Bactrim covers MRSA, and Keflex is like the greatest antibiotic ever created, okay? So I love me some Keflex. I'm always prescribing Keflex. So, yeah. So for this patient, I started him on Rocephin and either clindamycin. I think Rocephin and clindamycin because there were 2 IV antibiotics. I've never heard of Bactrim IV. I don't think Bactrim exists IV. Bactrim is another antibiotic for MRSA. Clindamycin covers MRSA. Rocephin does not cover MRSA. Rocephin is good for skin infections. I hope I'm not going too fast. This is not for you guys to really like learn. I mean, of course I want you to learn, but like learn because you're really going to learn in school. So I'm just kind of like mentioning antibiotics, but you just know that he needs antibiotics. So Rocephin is a really good antibiotic. It's like a cousin to Keflex, but it's a little more, it's like probably the IV version of Keflex, but Rocephin is I forgot. But so yeah, I always do Rocephin IV, Keflex PO. So I started this kid on Rocephin and clindamycin, I believe. Like I said, I'm pretty sure it was clindamycin. And this kid actually got transferred to the children's hospital because we don't have pediatrics at the hospital I worked at. We did not have pediatric services. So typically all our pediatric cases that need to be admitted, they get transferred unless the hospital has a pediatrician available or on call. So Motrin, Tylenol for any pain, and Motrin can help with some swelling. IV fluids, you don't need to like blast them with fluids because they're not septic, but always try to rule out sepsis with these patients and document that you have low suspicion for sepsis due to patients afebrile, patients not tachycardic, white count slightly elevated, lactic acid is within normal limits, patient non-septic appearing, boom, that covers. And then patient started on IV antibiotic, IV fluids, blah 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 blah, given Motrin for pain, to transfer to such and such hospital for continued service and treatment management of lymphangitis. Boom, that's your note. Okay, so I don't know what happens to him afterwards because we don't have access to that hospital's charting. I don't think we do. I think maybe Care Everywhere. Oh yeah, somebody said about checking on patients. Care Everywhere is a way to like see things going or patients' records from other hospital systems. So not all hospitals use Care Everywhere though. All right, so this patient had lymphangitis, cellulitis/lymphangitis. Cellulitis is just basically skin infection. All right, so know what's common, know zebras, know what can kill you. So this patient, what can kill this patient is if he had flexor tenosynovitis, if he had necrotizing fasciitis. I've never, ever treated a patient I've never treated a patient with necrotizing fasciitis. I hope I never do. That's like the worst type of skin infection to have. Like one day you're fine, the next day you're dead, literally. Not a lot of patients survive it. It's just a really, really bad, what I think is due to strep pyogenes. But it's just, you'll learn that in microbiology too. But it's just a really, really like the worst type of skin infection. So when you see patients with skin infections, I mean, if it's a simple cellulitis, but if it's bad, make sure that it's not necrotizing fasciitis. Okay, it's like I think it's like a gas-forming bacteria too. It's bad. Like you can lose limbs. Of course, you could die from it, but the survival rate is not good. Like literally, like I said, one day you're fine, the next day you're dead. So necrotizing fasciitis is not a good stuff. You guys can Google it. I had a doctor tell me he's only seen it twice in his life, but yeah. So like I said, know what can kill you. Know zebras. There's flexor tenosynovitis. Those are bad skin infections. Because a lot of times you see the skin, you think, oh my gosh, ain't nothing going on. Just see a dermatologist. Because skin is like so cosmetic-y, But there are skin infections that can kill you. What is it? Steven-Johnson syndrome. It's just a bad skin infection too. It's usually due to an allergic reaction to certain medications. But it causes like your skin to basically slough off. So I'm just naming some stuff that really need to be patients really need to be admitted for. This is not stuff for you to, like I said, remember or feel like you need to know just yet. At least I'm just telling you guys some stuff just to, I guess, so when you know about it or when you hear about it or learn about it, you be like, oh yeah. But this is for you to always know about when as a medical provider, especially in the ER. All right. So here, let me tell you guys the name. You guys can Google what it looks like too. To me, I mean, it's kind of cool stuff. Necrotizing fasciitis. I think those are the ones that I can. Yeah, those pics are not pretty. I know. So that's why I say when you see them, you'll know, or make sure that that's not what it is. Yeah. All right, guys. So any questions? Any questions, concerns, comments? Yeah, so now, and also I tell you guys a lot of these things because you're going to be asked them on rotations. So when doctors like try to pimp you, pimp is just like asking you a bunch of like kind of, they're not pointless questions, but a lot of times they do it to kind of taunt you and make you like, and embarrass you. So when they ask you these pimp questions, they'll probably ask you, oh, what are some emergent skin infections? You already know. You'd be like necrotizing fasciitis, Steven Johnson, flexor tendinovitis. You always have a quiz to do after every session. All right, guys. So hope you have a great Monday or week, and hope you guys learn some stuff. And there will be a quiz after. I'm not sure exactly when it will be posted, but check out later tonight or tomorrow. You should get an email notification too. All right. Any questions? Right. No problem. No problem, guys. How do I document this as eShadow? You would keep track of it on Microsoft Word or Excel or whatever, and then document it on Cast. All right. Bye, guys. See you. If you have any questions, let me put my email in my social media. Thank you, guys. Yes, eShadowing is every Monday, guys. Every Monday at 7 p.m. EST, unless I say otherwise on my IG. All right, let me go. Let me stop bothering you guys. Bye, guys. Happy Monday. Have a good day. Good night. Bye.